Hello, I'm Dr. Marla Shapiro, and I sit on the Board of Trustees of the International Menopause Society. And today we're joined by Dr. Peter Schnatz. Peter is an obstetrician gynecologist, and he'll tell us where he practices. And for women who are watching this, no, he's not a cardiologist, but he's going to talk to us about menopause and the heart, which is an exciting area. So Peter, please introduce yourself.
Great, thanks, Marla. And so nice to have so many of you join us today. My name is Dr. Peter Schnatz. I am the Associate Chairman and Residency Program Director in the Department of OBGYN at Reading Hospital, Tower Health, and on the faculty at Drexel University as an OBGYN and internist. So it's great to be here.
So for women who are entering midlife, that period of time of transition, who are bothered by hot flashes and night sweats, coming to see someone that they're thinking about, they're going to talk about menopause, you often have heart health front of mind. So explain why that is.
Exactly. And I think a lot of times women forget that heart disease is the #1 killer in women in general. And all women, that is the condition that they really need to keep front and central in their mind in terms of what are the risks and what can they be doing to help prevent heart disease throughout the course of their life.
So why is estrogen, the predominant hormone that we think about with menopause, a mediator, or is it not a mediator of cardiovascular risk?
So estrogen is not just a reproductive hormone. There are actually estrogen receptors in many areas of the body, believe it or not. And so even in the heart, on the vessels leading to the heart tissue that supply blood and oxygenation to keep the heart healthy, those vessels have abundant estrogen receptors. And when estrogen binds to those receptors, they can do many beneficial things during the reproductive years, keeping the vessel healthy, able to dilate in a healthy fashion, to keep blood flowing to the heart, keeping it from developing plaque within the arteries. At a certain point, unfortunately, we don't like to think about it, but as we all age, our blood vessels do begin to become atherosclerotic, fancy word for meaning heart disease or vessel disease. But as that happens, the estrogen receptors are lost. And then those potential positive things are lost and they can become potential risky things. So there's a timing factor there where earlier on, the estrogen can do things that are healthy. Later on, they may do things that are less healthy and even potentially dangerous.
So thinking about the notion of what you're talking about, which is timing and age as one point of entry into menopausal hormone therapy, does it make a difference if I'm a woman who lost my periods before I was 40, or if I lost my periods somewhere between 40 to 45 versus the more average age of menopause for most of the countries that are involved with the IMS, where typically it's 50 or so, country specific, but give or take a few years?
Yes, it makes a big difference. And so a lot of the data that women hear people talking about and maybe debating is in patients who are post-menopause, 50 to 80-year-old women. In the young, and so none of that data looks at the younger women, but we do have quite a bit of data showing that in young, healthy women, they really should be on hormones at least until the average age of menopause for their bone health, for their heart health, for their mental health, for all these conditions where estrogen, where the tissues have abundance of estrogen receptors. There's an importance for them to be on it, as long as they don't have a contraindication. But that is, and even data showing that women who are not on hormones in those younger years have a significantly higher rate of mortality, all-cause mortality.
So now let's get into an even more difficult period of time. So now we're looking at women, let's say, entering menopause in their 50s. So let's look at 50 to 60. And then a woman who comes in at age 60, having menopause for a decade or so, but now really, doesn't want to put up with those hot flashes and night sweats anymore. So those represent different decades of years. Does that influence the decision as to I, as a patient coming in to see you, having appropriate therapeutic options?
Yeah, again, for the women who are younger, and what we're finding in the data is that in the women who are younger than age 60 and within 10 years of their menopause, that is still in the window of time where the vessels are still healthy and amenable to some beneficial effects of the estrogen and keeping the blood vessel able to dilate in a healthy fashion
Mm-hmm.
and help prevent some of the early plaquing within those arteries. As again, the age continues to progress, as we get beyond the 10 years and the age 60, some of those potential beneficial effects are lost. And that's where it becomes much more important to have a discussion about what would the indication for using it be compared to the risk that might be generated by using it in those populations.
So really important to understand as women that how old we are and where we are in the continuum is really going to influence the safety or the option to be using this menopausal hormone therapy.
Exactly. And I think the buzzword that we've begun to use is individualizing
Right.
and tailoring it, because it's not a one size fits all. It's not hormones are bad or hormones are always good. It's a discussion that you need to have with a menopause expert, ideally, to help guide you.
So, I think back to several decades ago, but still, as a woman watching the news and what's happened, there's so much confusion that has been generated for women to try and understand what is safe, what isn't safe, what options there are. Firstly, where did the confusion come from? Is it just that women were not getting it, or is there a reason that we are so confused and so conflicted?
Yeah, no, great question. So we had all this data showing that hormones were beneficial, as you alluded to, and so we were so convinced as a medical community that women should be on hormones because there was all of these benefits. And so to kind of prove this, so to speak, several studies were designed to randomize women. Some would get hormones and some wouldn't. And guess what? We learned some important lessons through that. But the design of those studies used women that were older than we typically use hormonal therapy in. And so the initial results were a little bit surprising because we didn't see a benefit. It was basically a neutral effect, but we expected to see a benefit. And so that's where this kind of, wait a minute, what's going on came, and where it caused a little bit of panic. And now we're still living in the wake of that, where we're trying to help women understand that there are differences based on their age, their underlying risk factors, their general health, and where they are in relation to menopause. But the
So,
bottom,
listening to you,
yeah,
you made the point that not all women are the same
yeah,
and that it has to be individualized and tailored. But when this report came out, they treated it as if all women were the same.
right, right, exactly. And so I think again, as you alluded to, those that are on the younger spectrum, healthy, younger, without underlying comorbidities, this is very safe, and they can feel assured that this is not only going to help their quality of life, but not be dangerous in terms of some of the risks that their older counterparts may have.
So before I let you go, I mean, I think what I'm hearing as a woman, not with a medical hat on, but a woman who's, seeing a healthcare practitioner, is that vasomotor symptoms are not unrelated to heart health. Somewhere along this, estrogen is playing a role in giving us hot flashes or the lack of estrogen. So are the symptoms of hot flashes, which are related to the loss of estrogen, in some way speaking to us about the risk of coronary artery disease? And if so, how would putting estrogen or other menopausal hormone therapies back into the equation make a difference?
Yeah. So there are actually some newer studies coming out. Our group published one recently that is showing that women with more menopausal symptoms, a more intensity of menopausal symptoms, have a higher likelihood of cardiovascular disease. So there is some interrelation here. And one of the factors too that we've begun to hypothesize about is the role of the hot flash in being a sign that the vessel is still healthy. You know, in other words, when the vessel is healthy, it can dilate and then blood can rush through it, and you get the sensation of a hot flash. That maybe that's an indicator that the blood vessel still has the estrogen receptors and is it's still at a point where there isn't that risk of causing detriment. Some of that is still in a theoretical and theory phase, but there certainly is a link there, and it's an important topic that we're researching more intensely.
So I think as women coming to see a practitioner such as yourself or primary care, being troubled by hot flashes, to recognize that this is a much broader topic in terms of heart health and opportunities for prevention of cardiac outcome. And I think that that's the most important message I'm hearing from you. So before I let you go, for our women who are out there, is there one message that you want to leave us with?
Well, enjoy the menopausal years, because many of our patients say they're the best years of their life. And for those that are having significant symptoms, be encouraged that barring a contraindication, hormones can be used by many women in a very safe way to allow them to have good quality of life. Make sure to check on your risk factors for heart disease. Stop smoking if you can, or cut back, please. At least watch your blood pressure and your cholesterol, and look at all those factors. Get exercise, the things that you can do to lead a healthy life and enjoy these menopausal years.
Well, thank you so much for joining us today.
Thanks, Marla. Take care.